sure, I will announce tomorrow that when we are leaving, sign out. Don't sign 9 to 1 if you're not staying. And that's okay, it's a 2-session, wherever you're staying, just sign out. So I'm going to go ahead and start because a lot we have to finish is, I'm done, is a lot of your colostomy, ileostomy question, and I'm moving on diverticulosis. When we see a patient or question, it's going to be diverticulitis. So everyone knows what is diverticulitis? Infection. Itis means infection, but remember the word diverticulosis. There are the pouch. Diverticulosis means there are the pouch in the intestine. So underline the word sac, like outpoaching in the wall of where? Large intestine. They have like a small pouch. And what happened there, it can lead to infection. So when patient is admitted with diverticulitis, remember they have infection and there's inflammation. Why? Because trapping of the food in the pouch. And what do you monitor? Underline the word inflammation, abscess, and perforation. So number 1, infection. Number 2, inflammation. And number 3, what are we monitoring here? Perforation. It can perforate. And what is the pain? Very important in diverticulitis. So the questions are going to be, patient is admitted with diverticulitis, they have pain. And where is the pain? Left lower quadrant. Underline that word. Pain increases with coughing and staining. When patient is staining, cramping they have. Underline the word fever. So remember, we got to treat the fever first because there is infection. And what does the patient has? Blood, maybe the blood in the stool and cramping. So everyone remember the word diverticulitis, infection. And what do you, your priority here is in treating the infection. Now where is the pain? Left lower quadrant pain. What do you monitor patient when they have infection? Number 1, the blood test we do is called CBC. What is CBC? Is complete blood count. And what are we monitoring patient here for infection? What is another thing would be here? So increasing your white blood count, infection, and ESR. You have written there sedimentation rate. So what is sedimentation rate? Is ESR, that's showing inflammation. Barium enema can be done. Endoscopy can be done. But underline the word barium enema, contraindicated. You cannot give a patient has acute diverticulitis. So patient comes with acute infection or diverticulitis. Remember, you're not going to do barium enema. Why? Because it can cause perforation. It can cause perforation. What do you do when patient comes with diverticulitis? Number first, read your question. Patient is admitted. First thing is bed rest because they have a lot of pain. NPO. And what do you give them? Whether you are giving PO fluids, and write down IV fluids. So what are we increasing here? Fluids. What are we cutting down? Write down the word, cut down the fiber. No fiber. In acute stage, very important, you are lowering fiber or you are not giving fiber. What are we increasing here? Fluids. So very important, and treat infection. Write down the word antibiotic. It's important to treat infection. Then what do you do afterwards is, if we have patient with diverticulitis or diverticulosis, they need to eat more fiber. Underline the word increased fiber and increased laxative. And what kind of laxative we have is bulk forming laxative. Everyone must know what is bulk forming laxative is Metamucil. What is Metamucil is, you mix it in the glass of water, and what do you encourage patient to take another glass of water? So what is a bulk forming laxative is Metamucil. And what do you tell the patient to eat fiber. And I want you to add there, whenever we are giving bulk forming laxative, which is, I said Metamucil, and what do you increase here is the fluid. What do you increase here? Fluid. So make sure we write down Metamucil, and you are increasing fluid for your patient. So what diet do you give? First you low fiber, restrict fiber, give fluids. But once patients stabilize, what are we teaching them to take fiber? Metamucil, increase fluid, and avoid seed food, right down on the top. Avoid food trapping in diverticular means anything with the seeds, don't give them. And small amount of bran, because that also is fiber. Fluids is important, medication for antispasmodic medication. Crohn's disease is very important also. What is Crohn's disease? Is inflammation and terminal ileum. Underline the word terminal, part of the ileum. And what happened with inflammation? It becomes thick, swelling, and scarring. So it forms the scar. And what does it do? We use the word narrow the lumen. What is the lumen? Means inside that area becomes smaller. So what is it? Narrowing lumen. That means the food cannot pass. And also it can lead to fistula, ulcers, and abscess. It's a bad disease. And Crohn's disease are inflammatory disease. And thickening, swallowing, and remember, it can cause excavation. Excavation means they get very sick. Remission means it gets a little better, but it never goes away. It's there. And it flares up and patient feels better. Remission. Excavation means acute attack. How do we diagnose them? By giving barium study. And when they give barium, what do they see? The test is called, with the barium, a string sign. What is a string sign? The barium you can only see like a string. If you're giving barium and the lumen is open, you will see a lot of barium, and barium is a white color. But what does it see like a string? That means narrowing of the lumen. So what test do? We give them barium, and what would you see here? The string test. And what is string test? Means narrowing of the lumen. What does the patient has? Fever, cramping, and colicky pain after the food, and containing mucus, pus, and also you can look in the anemia is important here, and electrolyte imbalance and abdominal distension. What do you give them? Low residual diet. And I want you to add there, you can increase protein because they have very much low protein, and 100-gram protein a day. So add their low residual diet. Low residual means fiber. You can give vitamin, you can give iron, and you increase protein. And sometimes when they can't absorb it, they may get TPN. TPN you can add there, may be also used, and high nitrogen part, they give it in the TPN. And I said protein. And also medication. What medication they give them are in treatment? Low residual diet, sedative, underline the word steroids. They're treated by steroids. Immune compressive medication. Immune compressive medication like Sand Immune. I will write down one of the drug is common Sand Immune. That is also for immune suppressive medication. Sand Immune is medication. So immune system, anti-diarrhea, and sometimes patient doesn't want to eat because cramping is bad, and they lose a lot of weight, and surgery may be done. Now the last page on this is vitamin, and I'll tell you everyone, I have attached one page in the back. And why I attached this page, this is from your adult health book, not adult health, your foundation. When you guys have done your food, a lot of food questions are coming in exam. You do have here, but I'm missing some of them. So everyone, I want you, everybody has, no, that's not the page. This page, everybody has it, and the back, I know.
This one?
No, that's a drug page. In the back, you don't have this? Everybody, electrolyte is separate, but you should have extra. None of you guys have the page? No, not electrolyte. Oh, you have with electrolytes?
It's behind the electrolyte.
Oh, okay. Let's see.
Oh.
You do have, okay, behind electrolytes, okay. So let me show you, I like it to go behind here, but let's see this one. And also you guys have some here. But let me show you here because some of the things are missing. And you do have thiamine in your notes, but let's see page number, there is a page number 621. And 621 on the top you have niacin on this page. This page, you have both sides, and I want you to highlight here because it covers everything. And first thing is niacin. What is niacin is B3. And what is the disease here? Comes in exam, pellagra. So go on the fourth box. Fourth box is called pellagra. Comes in exam. And if they give you pellagra, pellagra is deficiency of what is niacin, or we say is B3. So what is niacin is pellagra. What is pellagra? Underline the word dermatitis. They have rashes and constipation, but very important, dermatitis. So remember, what is pellagra? Dermatitis, and they have rashes. And constipation and dementia and depression. Everyone should know the word pellagra, and pellagra means rashes. Okay, the next one, B6. B6 is pyridoxine cause anemia. Folic acid is also leading with anemia, but what kind of anemia? Macrocytic. What is macrocytic? Large cell anemia. B12 is for pernicious. Are you okay? You got the page? Okay. B12 is called, what is another name for B12? Cyanocobalamin. What is cyanocobalamin? Are pernicious anemia. And what is pernicious anemia? The food. Second box, you guys have food there. And the last one, everyone should know, vitamin C. What is vitamin C? Is called ascorbic acid. And when you're missing ascorbic acid, is called scurvy. So everyone, remember, in NCLEX, you have pellagra, you have scurvy. And what is scurvy? Is gingivitis. That means the gum bleeding. And wound healing, remember, why do we give vitamin C? For proper wound healing. But also it can lead to muscle in the gingivitis, which is called the scurvy. Everyone is okay? The name, sometimes name is, we are not aware. Let's go to the other side of the page. Vitamin A. Vitamin A leads to night blindness. And what is night blindness? Is for the eyes. And vitamin D is also called calciferol. What is vitamin D? Can affect the bones. And what does the disease is called? Rickets. Rickets is in the children, abnormal shape. It's a bone problem, abnormal, but rickets is in children. Osteomalacia is in the adult. Then I want vitamin K. Vitamin E is antioxidant. Vitamin K is for bleeding. Thiamine, everyone should know, is thiamine B1, berry. What is berry? Is mental confusion. Underline for chronic alcoholism. When I will talk about mental health and patient admit with alcohol withdrawal, very important, we give them thiamine. Why? Because it leading to chronic alcoholism is also mental confusion. Everyone is okay? That's called your thiamine. B2 riboflavin is affecting sore throat. Chiliosis means lip. And the food came in exam. Milk, meat, poultry, fish, enriched fortified grain. So you guys, diet is very important. These 2 pages, I did have some here. I like it not to forget others, so attach this one with this page. I like it quickly because we don't have is appendicitis. I want to add their appendicitis before I go in electrolytes. Few wording. So you guys can add on your GI package appendicitis. A lot of questions are coming in appendicitis. Where is the pain in appendicitis? Where is the pain? Right lower quadrant. Everyone write down right lower quadrant. And what is another word we call? McBurney point. Where is McBurney point is from the umbilicus area in between right iliac crest. So where is McBurney? Now, sometimes they don't give you McBurney and they said patient is admitted with appendicitis. Where are we going to assess? In the between umbilicus and right iliac crest. So write down between, where are you monitoring, is umbilicus. Remember, umbilicus area and right iliac crest. Everyone is okay? Is the hip bone. Iliac crest is in the hip right here. It is on the right side lower quadrant, but just they're looking, do we know where is right lower quadrant? So we are looking for the side. Now I want you to write down, they have abdominal rigidity, rebound tenderness. Those are very important signs. Rebound tenderness. And rebound tenderness is affecting, is in the lower area, and fever. Whenever patient has appendicitis, they have infection. And what do they have here is fever. What do you monitor? Write down CBC. What would be high here? White blood count. What would be high here? White blood count. I want you to write down there NPO. Don't give anything by mouth. No heat. Don't apply any heat. Don't give any food. What position patient may be laying? On the right side because they have pain. So remember, there is no enema, no suppository, no heat because it will rupture. What is the complication of appendicitis? I want is to write down the word peritonitis. What is the problem here? Peritonitis. After appendectomy, what do you monitor patient position? Right side, they can turn on the right side, or semi-Fowler position. You must have your patient in semi-Fowler's position or right side. What do you assess? Bowel sound, bladder, and what drainage system they have. I want you to write down the word Penrose drain. So I want everyone, appendicitis keep coming in exam, and we must know where is the pain? McBurney point. And where is the McBurney point? Between umbilical and right iliac crest. What do you not give patient here? Nothing by mouth. What are you monitoring? Infection. What blood test are we doing here? CBC. What would be the position patient would like to lay down on the right side because they are hurting? And patient is going for appendectomy. And when they come back, what position? Everyone, they can turn on the right side and they can go semi-Fowler's. What are you assessing before you give food? Bowel sound. Also check bladder and also what kind of drain they have, Penrose drain. So I wanted to add appendicitis, and now I want you guys, so we already know we already finished is hepatic and GI. The last thing I want to guide you with is electrolytes, and also what is in electrolytes, we are looking here, sodium and potassium. And make sure you guys, we all are taking the exam and your level of the blood test. So first thing is potassium. I don't know where you're learning, whatever we are learning, some books will have a little bit different, but everyone should know the potassium is very important. When the low potassium, I have normal values there on the first page, 3.5 to 5.1, and you might have a little different somewhere. And second box, everyone must know the food for potassium. You have bananas, cantaloupe, and that. Hypokalemia, which patient you have low potassium. Now, this is intervention, but let's go causes. Everyone remember, when do we lose potassium? Causes of hypokalemia. Number one, diuretics. When you're giving diuretics, what do you lose? Potassium. Underline the word suction. When you attach patient with suction, coming in exam, what do you monitor when your patient is with suction? You lose potassium. Second thing is Cushing patient. And when you have low potassium, underline the word diabetic patient. When diabetic, DKA, write down their word DKA. What is DKA means is ketoacidosis, and they pee more and they lose potassium. Then alkalosis. Whenever you have metabolic alkalosis, remember your potassium level is low. Now intervention, you give potassium. And before you give in intervention, let's go intervention and underline, check the kidneys. And if you're giving oral potassium and a patient complains in fourth line pain, nausea, vomiting, you stop. IV bolus injection, you never give IV push, but you got to dilute IV. So before you give potassium, what do you check? Urine. What do we check? Kidneys. Are we clear? So it will take a while, but I want to give you the package because we got to know when do we lose potassium, when we are giving diuretics, when your patient is Cushing, they have low potassium. Which are the patients? Suction patients. What are they losing potassium? Whenever patient has metabolic acid alkalosis, that potassium level is low. Where does it affect? Is your abdominal cramping. Underline the word hypoactive bowel sound. What will happen when your potassium is low? Hypoactive bowel sound. It affects the heart also. Now hyperkalemia. First thing is your normal level, you should know. Hyperkalemia means too much of potassium. And what do you give to lower the potassium? I want you to highlight the word G-Electrolytes in second line. Everyone should know how do we lower the potassium? G-Electrolytes. Third line, you can give dextrose with regular insulin. And the third thing is you use the fresh blood, because when you use stored blood, your potassium level is high. So how do we lower the potassium? Number one, G-Electrolytes. Number two, giving regular insulin with dextrose. And number three, use the fresh blood when you are giving. Avoid last line, salt substitute. Your salt substitute are very high in potassium. Next page, which patient causes when you are giving potassium? And always when you are giving IV potassium, monitor cardiac. Because if you give too much potassium, what happens? The heart is affected. So what do you monitor when you are giving potassium IV? Make sure your cardiac monitor, because it's affected too much of potassium. I want you to write down the wording in causes. Are renal failure. When your kidneys are failed, no urine, your potassium level is high. Second thing, Addison. I want you to underline that word. And salt substitute, very important. And also obstruction. Whenever you have high potassium, patient is in metabolic acidosis. Underline. So remember, acidosis, what is high here? Potassium. What do we do when patient has potassium? Sign and symptom. They will have diarrhea and hyperactive bowel sound, and monitor heart, cardiac. Everyone should know sodium. All electrolytes are very important. And it's a GI, patient has nausea, vomiting, patient is losing potassium, patient has gastric suction, losing potassium. Sodium, very important. The food you have for sodium is your bacon, your meat, cheese, hot dog, all that food are high in sodium. What intervention do you do when you're giving sodium? Is avoid tap water enema. Use normal saline. Hypo means low sodium. Causes, very, very important when you lose sodium, when you are giving diuretics, suction, underline that. Very important, SIADH. What is SIADH? Syndrome of inappropriate antidiuretic hormones. So write down that, SIADH. And what gland is that? Pituitary gland. And what is the problem here? ADH. Write down ADH on the side. So when you're giving diuretics, you're losing. SID patients, you're losing. Diabetic ketoacidosis also you're losing. And also when you're perspiring, and also your patient with renal. Now also your patient has CHF and renal failure, that means you're retaining fluid. Now remember, whenever you have is hyponatremia intervention, nobody should forget is whenever you have low sodium, that means your body is retaining fluid, and which patient we said monitor? SIADH. And what do you cut down here? Fluids. Why? Because they are retaining more fluid. So remember, low sodium in intervention, highlight the word restrict fluid. And what do you monitor here? Patient for SID are number one, you monitor and don't give fluids. Hypernatremia. Which patient you have hypernatremia is diabetes insipidus in causes. And Cushing, you have more sodium. And when you are giving enteral nutrition and parental fluid can cause hypernatremia. Next page, you will monitor for hypernatremia, means dry mucous membrane. Remember, they're dehydrated. Write down there, increasing fluid. Two things in your simply mind, hyponatremia, no fluids or restrict fluid. So much more sodium, increased fluid. Like this, you remember in electrolytes. Are we clear? And next is calcium. When we talk about endocrine system, everyone should know where do we get calcium? From parathyroid gland. So write down there, hypocalcemia, low calcium. What do you monitor? Intervention. Is Chovastic and trousers sign? Underline in intervention. What is Chovastic and trousers sign? Twitching of muscle. Then we underline the word low calcium can lead to seizure. And what do you give them in the last line? Calcium gluconate. Causes, which patient are you losing calcium? I said diarrhea. Underline when you have diarrhea. Renal failure patient, very important, we know. And pancreatitis, I just did this morning, and I said keep them available, calcium gluconate, and Crohn's disease and parathyroid gland. Hypercalcemia, too much of calcium. And what do you monitor also? Dysarrhythmia. And second line, urinary stone and fracture. Now, which patient you have hypercalcemia? Write down on the side, hyperparathyroid gland. Now remember, calcium low is immediately you don't think about fracture, but think about the muscle. So if you have too much of calcium, we monitor patient for renal failure, and you monitor pathological fracture. Everyone write down that two wording, and you have it there. And calcium, food you have here, what food you will give it to them if you have hypocalcemia. So we have talked about hypercalcemia. Next page you monitor. For hypercalcemia, also sign and symptom, heart, constipation, and also muscle weakness. Magnesium is also important in electrolytes. Hypomagnesium, when you have hypomagnesium, underline dysarrhythmia, you have heart problem. Monitor vital sign. Which patient are we losing magnesium? Diarrhea, causes, Crohn's disease, alcoholism, eclampsia, pancreatitis. What are hypomagnesium affecting reflexes? That means DTR, tetany, seizure. Hypomagnesium are low magnesium. It will take a while, but you guys need to know your normal level. and some calcium, sodium, potassium, magnesium intervention. When you go next page, and what do you do for magnesium is diuretics, you can give them. Laxative, you can give them. Phosphate is the next one. Phosphate, hypo and hyper. What happened? Hypophosphate is monitor respiratory, and the third line, neuromuscular activity. What are the reasons for phosphate? We have hypo is malnutrition, hyperparathyroid, very important because they have more calcium, diabetic patient, ketoacidosis. When you have low phosphate, what do you monitor? Bone pain. Why? Because they have low calcium. Because phosphate is lower and too much of calcium, they have bone pain. Seizure, you can monitor. That you can highlight. And last one, hyperphosphatemia, too much of phosphate. And why? Intervention. When you have too much of phosphate, we are giving amphogel or ammonium hydroxide. And what do you monitor if you have too much of hypophosphate is tetany. Avoid laxative, avoid phosphate containing medication, and causes are excessive of too much of phosphate will lead to hyper. Hypoparathyroid patient has sign and symptom, hyperactive reflexes. I want you guys to read through, and every system when I'm talking about it. And the third thing I gave 2 pages of your drugs, and make sure we talk about some of the drugs. But I want to show there are 2 packages you guys have, and we already talked about some of the drug. And I want to show you on the first page, you have antacids, and we talked about some of the antacids, ammonium hydroxide. Second page, you have other drugs for GI, and we did talk about Prazole, but I gave you for diarrhea. What medication do you give on the second page? On this one is Kaopectate. Kaopectate is for diarrhea. And what does it if you give diarrhea medication? This is the page I'm going over, and second page you have is diarrhea medication, Kaopectate, Lomotil, Imodium, and Paragoric. So start memorizing name, and then the next page we already talked about Carafate. Then you have another page about electrolytes, calcium. We already talked magnesium, potassium, and you have some more laxative at the end. So I like you, and the last page you have some drug. Now this is another package extra. I have made copies because there are medication you have on Gamazar, that's a pancreas cancer medication. Lactulose, we already talked about it. On this page, there are 2 sections on this page. There are both sides. On one side, you have medication for gallbladder and liver and biliary. Make sure you guys have 2 packages and start looking. Lactulose, we talked about it. They can give Demerol for pain. I talked about that. Probenthine, I talked about. Pitracin, I talked about. And also neomycin, we talked about. Are we clear? Then the next page, you guys have here antacids here. Bentyl, we talked about. Probenthine, we talked about, and Tagamet. So you can read side effect. You need 1 copy, I'll give you. So make sure you should have both sides, these packages, and keep together with GI system. So we closed here with GI, hepatic, electrolyte, and some of the drugs. And let's start memorizing our labs, okay? Thank you.